Good afternoon. Welcome to the conversation. Today we'll be talking about the pandemic and prisons. I'm Professor Evelynn Hammonds. I teach the history of science and African American studies here at Harvard. I'm also director of the project on race and gender in science and medicine. The format for today is that all participants will have muted video and microphone during the conversation. There will be a 15-minute Q&A after the conversation, and please post your questions using the Q&A button on your screen. Slides and recording of the conversation will be available in 1 week on the website as you see the link on the screen. And after the conversation, please continue to send questions also to our website. And soon we'll have suggested readings from each conversation which will be available. Also, just to remind you about the Q&A, during the conversation, the chat function is for comments between participants only, and during the Q&A, which is the last 15 minutes of the conversation, please post short questions for myself or Professor Thompson. Thank you. So today, the pandemic and prisons. I'm happy, very happy to be joined by Heather Ann Thompson, who is a Pulitzer Prize winning historian and from the university and professor of history at the University of Michigan in Ann Arbor. She is an award-winning historian, written a number of books. Her most famous one is about the Attica prison uprising of 1971 and its legacy. And she writes regularly on the history of policing, mass incarceration, and the criminal justice system for a number of scholarly publications and newspapers and magazines. Thompson has served on the National Academy of Sciences Blue Ribbon panel that studied the causes and consequences of mass incarceration in the United States, and has worked on congressional staff briefings on its much cited findings. So I'm very happy. I should say, she's currently writing a new book on the MOVE bombing of 1985 and a book on law and order in America. So welcome, Heather. I am so excited to have this conversation with you, though it's on a subject that is incredibly sobering, disturbing, and unsettling. But you have written so powerfully about the ways in which COVID-19 is impacting those who live and work in prisons, who are incarcerated, their families, and the broader community. Could you begin by telling us what is happening in prisons in the wake of the pandemic? I'll move the slides forward for you as we talk.
Sure. Well, first of all, thanks so much for having me here today. And I'm really grateful that we're going to be able to bring prisons into this conversation about public health and about the coronavirus, because it is increasingly in the headlines, but I fear that the very reasons why it's in the headlines always exist. And so we need to kind of think about this more than we do anyway. And this is a really good opportunity for us to kind of touch in with this question of what is going on behind bars that is making the prison so much more susceptible to coronavirus than a lot of other spaces in our society. And to really get a sense of how serious that is, at one facility, just speaking randomly, the Marion Correctional Facility in Ohio, for example, almost 90% now of the people inside have coronavirus. And, you know, I think you have a slide we can show folks to point out that the people getting this inside, this does not discriminate between persons who are serving time and persons who are working there. This is both staff and prisoners alike are getting infected, and it's very scary because none of them, neither the guards nor the prisoners inside, have the opportunity to social distance. They already have horrendously overcrowded and unsanitary spaces, and they already have substandard medical care. And of all populations, the folks inside have really some of the worst pre-existing conditions. And so for all of those reasons, these are spaces where corona is escalating, and why we should care beyond the kind of fundamental human rights and humanitarian concerns is that this is really laying bare the fact that prisons and the broader society are quite porous. The walls are very porous, and so we can't afford to ignore this inside.
It's really interesting just looking at this graph of the cases. They track so closely between the staff and the inmates.
Mm-hmm.
And so that is just, anybody looking at this graph would say, but that just makes your last point.
Mm-hmm.
The walls, people inside, there's no inside and outside.
That's right. And the scary part of it is that for the people who work there, for example, they're bringing this home to their families. But of course, anyone who visits a loved one inside who's serving time is also bringing this home to their loved ones. But the people inside themselves do not have any opportunity to protect themselves from it. They literally don't have the labor laws in the case of the guards to make it possible for them to stay home. And for the folks inside, they don't have the basic human rights to have some space from one another or the health care that they need. So it really lays bare what prisons look like for all concerned every day, but in this case, much more with a much higher cost.
Absolutely. So you have attributed the horrific situation occurring right now in prisons, in part to what happened in US prisons in the 1990s when there were outbreaks of tuberculosis in many prisons. Mm-hmm. So tell us about what was happening in the 1990s that partially set the stage for the spread of the coronavirus. And I really want to understand your point of view on whether political decisions were determinative in what happened, or public health practices, or both.
Mm-hmm. Yeah, that's a great question. So interestingly, when I was thinking about trying to get my own head around what is happening with COVID right now in prisons, I think everyone sort of understood that these were unsanitary, crowded spaces, and so were perhaps not surprised that the virus spread. But what I didn't think people really understood is that we actually should have known that this was going to happen, and that we had an experience, actually a number of experiences historically in prisons where epidemics have played out. And we had opportunities to learn from those moments and learn about the porousness of the walls between the inside and the outside, to learn about the importance of how we treat folks on the inside from a public health point of view. And the one I chose to really look at in a piece I recently did was tuberculosis, because it's really striking with TB. TB, like corona, is a airborne contagion. It's highly contagious, and it tends to flourish in very crowded spaces with people with pre-existing health conditions and who are not able to socially distance and so forth. So it was a really interesting kind of comparison. And the other reason I wanted to look at tuberculosis was it's a perfect example of how these contagions, that from the public health point of view, can be completely man-made. Or the crisis is completely man-made.
Yeah.
The crisis is man-made. So in the case of TB, tuberculosis in general had been going down dramatically after the 1950s across this nation. And there was a pretty horrific spike across the country in dense inner cities and in prisons, but New York was a particularly notable case.
Can I just interject one thing about New York? And New York, in the 19th century, throughout the 19th century, was a place where there was always a lot of tuberculosis up until, right into the 20th century.
Exactly. And so just as it took the will and the political will and the scientific determination to eradicate TB, or at least to beat it back so dramatically as had been done between essentially 1950 and 1980. It was deeply alarming when prison officials first began to notice it spiking again in prison. And it was alarming for two reasons. Number one, because it was so quick, so rapid. The number of cases in New York's prisons went up by about 900%, seemingly overnight.
900%?
Yes, and of active tuberculosis in the New York Department of Corrections, and the staff were getting sick, not just those who were there serving time, and the strain that was showing up was more virulent. It seemed to be resistant to all methods of treatment. And so there was a lot of hand-wringing inside about how this could have happened. And lo and behold, lots of studies were done, and they figured out that for one thing, it made a difference that the healthcare was so bad in prisons. It made a difference that the crowding was so bad. It made a difference that people had pre-existing health conditions. HIV, for example, was one of, which is a key one. But in that moment, and this is really, I think, the point, there was lots of wisdom to go around about, number one, how you make prisons less toxic places for both staff and folks inside, but also why this is a public health question for people on the outside.
Yes,
and
but also they knew a lot about tuberculosis.
Exactly, they knew a lot about the actual.
It wasn't a new disease. It wasn't a novel virus.
Exactly. So you have the makings of a real breakthrough, if you will. You have the makings of let's learn some lessons from this scary moment. And if you look at this graph, it kind of looks like the lessons were learned. There is a real concerted effort to get TB under control, not just in prisons, but in the poorer neighborhoods where it in turn was showing up. And yet, this is a very, it's a misleading graph in so many ways, because while it's true that TB does go down, the very conditions that made it erupt, the very conditions that made it spread so easily between prison and the outside were not addressed at all. And in fact, 2 years later, I argue that the conditions were doubled down on. Both by passage of the Violent Crime Control Act under the Clinton administration, that essentially ensured that prisons were going to get far more overcrowded.
Yes.
And, it's federal legislation, but it incentivized the overcrowding of state prisons. And then 2 years right after that, what limited access the poor had to healthcare, both inside and outside, because of course, folks on the inside also utilized the welfare state, was gutted with the Welfare Reform Act. And so rather than heed this kind of the lessons of this particular epidemic, we doubled down on all of the things that made these things possible. And it's not a linear, it's not a totally neat linear line from TB obviously to COVID, but it is deeply instructive that we reaped what we sowed. And I think that's really the thing we need to think about.
I mean, I think because what you're saying is we did understand, our public health experts understood tuberculosis. They understood that once it sedimented in a prison population where you couldn't separate people and isolate people effectively, that it was going to spread, and it did.
Yes.
And it peaked, but it also, and I think one of the important points that you've just made is that it's also connected to public policies outside of prison that led to an expansion of the prison population and made people who were going in come from more vulnerable populations than they had previously.
Exactly. And in fact, I've only been speaking now, and even in the piece I did, about sort of the more specific connections between prison populations and, for example, the Violent Crime Control Act or the Welfare Reform Act. But the reality is that the reason that COVID has had such root in cities like Detroit, where I live, it's because of the impact of those pieces of legislation, this punitive turn overall has wreaked havoc on the social safety net. Now we knew that, we no matter what you see it everywhere, we write about it, we sort of knew that. But unless we are writing the history of health and medicine, or unless we're a public health expert, we often don't make those connections about what the true societal costs of those political, that punitive turn. Yes, we built more prisons. We know that. Yes, we became more, we became a harsher, more punitive nation. But how that has really had public health implications, I'm not sure we've spent sufficient time on.
So I guess in one sense, your answer to my question, what was more determinative, public health practices or policies, and I guess plain old politics are also very difficult to separate. And the public health policies or practices sort of fade into the background, and what we know about is more of the sort of political aspects of changes in the social welfare system and how it's been responding to general issues of poverty and the absence of good health care.
Well, that's right. And what I actually think is quite interesting is that it's not that we haven't in recent days and months been talking about the politics of COVID or the political decisions that weren't made or could have been made that could have made a difference on the ground in communities like mine in Detroit. But what we haven't, but that's a very immediate political discussion. It's a very immediate political discussion about, did we socially distance quickly enough, or did we have enough PPE, or did we do enough to actually stem this? And we're not having the discussion about the fact that we could have done all of those things, but we have already made this worse by having this punitive turn. Yes. And frankly, we see these people showing up in capitals, armed to the teeth, demanding that businesses open. And that is also a result of this punitive turn. People need to work so desperately, in part because we have gutted the safety net that allows them to not work in moments such as these, right? How much money they could get while not working has been eroded. And so it's all connected in really powerful ways that it would be so tragic to not kind of think through on the policy level moving forward.
No, I think that's absolutely right. So this slide points to what you've been saying about the expansion of the system of mass incarceration. Do you want to just comment on that a bit more?
Yes. Excuse me. You know that this is going to happen. Hang on. Of course, when we do this from home, inevitably the animals will get in our way. Yes, one of the reasons I just wanted to share this slide is I'm sure folks who are joining us, I mean, this seems like information that everybody has, which is what prisons look like and how deeply racialized and disparate prisons are. Mm-hmm. But I want to put that up there to really digest it, not in terms of prisons, but what that connection is within public health. Okay. It is not, the fact that the city of Detroit is suffering so much more than the rest of Michigan right now has everything to do with this slide. Mm-hmm. There are neighborhoods in Detroit right now where 1 in 16 people are under some form of correctional control. Wow. And that means that these are people who are one of these figures you're seeing on this graph are people who go in and then they go out of our prison system. And the same prison system is the petri dish for these really horrific contagious diseases and other forms of disease. And so there's a lot of hand-wringing about, my God, I watch these politicians and these reports, why is a city like Detroit hit so bad? Or why is Chicago hit so bad? Or why is you know, why are areas where you are hit so bad? It's this. It is the fact that it is racially disparate. The punitive turn was racialized. The punitive turn hit different communities very, very differently. And so it is true that COVID doesn't know race in the sense that anyone is susceptible to it.
Yes.
But it is equally like TB, right? Anyone could get TB, but you can't really understand the public health impact of COVID without understanding the racialized punitive turn. And so that's the what I was sort of kind of introducing here.
Mm-hmm. Mm-hmm. Yes, I mean that's part of what my next question. I think that it's easy for people to think about some of the structural problems of, you know, space in prisons, for example, or the fact that the staff moves in and out, or that it's difficult to social distance, and focus on those things and not focus on what you try to show in this slide.
Mm-hmm.
And so my point is, and my question was, how would you describe what you've pointed out about the racialization of incarceration in the United States, but also how race, or I'm not sure if we should say race or racism, is producing this kind of disproportionate impact of the pandemic, both within prisons and in poor Black communities where so many of the prisoners are from.
Yes, I mean, the relationship between those two things is fundamental. It isn't just that communities are poor, it is that those poor communities are disproportionately policed and imprisoned. And in turn, the fact that these are communities that are disproportionately policed and imprisoned makes them much more susceptible when an epidemic arises. And that is, it sounds a bit cyclical, but it is a really important life cycle to think about. But it's also true that it's another reason I want to call attention to that. And that is that so much of the reporting that has been done on COVID in prison has really focused on this question of space, as you just said. Right. There just isn't enough space, and that the problem is that, you know, people cannot socially distance, and that's true. But the far more the more alarming, or really more troubling element of it is that why that was ever allowed to exist to begin with, why it would be that you would have a prison that was built for 600 people with 1,300 people crammed in there, why it would be that you would allow any human being to be in one of those places for 30 years or, you know, 30 minutes. And so it really forces us to ask these other questions about prison. And this slide has everything to do with that as well, because of course, if the slide was reversed, if the slide was racially reversed, it is hard to imagine all of that. It is hard to imagine how long people were in prison. It is hard to imagine the confinement, the overcrowding, the insanity. And again, there are white folks in prison too, and they're poor white folks, and people don't care a lot about them either. But it makes it easier, and I'm waiting for the data to be released. But I think it's going to be interesting to see the compassionate releases that have happened. There've been far too few, but who is getting released in light of COVID?
That's a really, really important question, and it's happening across the country, it seems to me, in a very fragmented way. So is it true that it's left particularly for governors to decide on what constitutes compassionate release and how much should happen? Is there a federal policy around that?
Well, it's mostly, unfortunately, this is where states' rights can go really right or can go really wrong. It totally depends on who's in charge. Certainly the clemency decisions are coming from the governor's office across the board, but you know, it matters a lot who the DA is. It matters fundamentally who the DA is at the local level, whether or not the DA is fighting against folks who are trying to let folks out of jail, let people go home from prison that are elderly, dying of a disease, because again, this is where this punitive turn has everything to do with why prisons are so bad right now with COVID. We have had now 30 years of these long sentences. So not surprisingly, the prison population is a concentration of really elderly people. Yeah. And they are also more susceptible. So we are fragmentarily, where the policy is fragmentary. It totally depends on whether the DA is a progressive DA or not. And frankly, we don't even really know what this is going to look like when COVID peaks and passes, because it raises these ethical questions. If you let somebody out because they are too elderly to withstand COVID inside of a prison, or you have clemency because they should never have been, or you let people out of jail because they're only there because they can't afford bail, it seems to me this raises huge ethical questions for us as a nation, which is why were they there in the first place?
Yeah. Yes.
Why do we have 12 million people circulating through our jails just because they can't afford bail? Or why do we have so many elderly people in prison? And I would love to think that this is an opportunity to really push the already, existing important criminal justice reform discussion, but to push it forward through a public health lens. And I think that's been a lens that it's always been there, but it's really been a shadow part of this discussion.
I'm struck by that point, that the public health part is the sort of shadow behind the front side of this discussion. But also, I am struck by the numbers. These are really large numbers, Heather.
Yeah.
Is it possible in terms of curtailing or mitigating, or I don't even know what part of the system we're in now, mitigation or containment, or even testing the numbers of people that are in prisons?
Yeah, I mean, this is what's horrifying about it, right? Because the last people who will be tested are behind bars. So we know that. And yet we already know that if we ever imagine getting a hold of this outbreak, if we ever imagine ending this pandemic, if we don't look at prisons and you have 80% of some of them with people who are sick, we're not even the scientists, right? Dr. Fauci is not talking about this. So it is quite daunting. We are talking about a resurgence in the fall. We're talking about what would it mean to end social distancing too quickly in a state like Georgia, but we are not talking about the fact that we have 2.5 million human beings behind bars in prison, yes, who are now, if not sick, potentially carriers of this. And we have the countless millions more who are in jail. I have not to date heard a public health professional speaking on behalf of sort of the national health, talking about what the implications of that are for moving forward. It's deeply alarming.
And so there's a public health aspect of this, being ignored, as you just said. But also, I'm struck by how the numbers represent also a set of legal issues around compassionate care and compassionate or releases based on the fact that people are elderly, the cost of maintaining them in prison, or the possibility of supporting their lives in prison has become extremely limited. And then we reach a point and say, and then what? Again, what? I guess I'm trying to figure out who will take that on. Who do you think should take this on? Because it's clearly not going to go away. And if we keep going back to the other point, there's no inside and there's no outside. They have to be part of the ultimate solution.
Well, I hope so. And of course, the looming concern always when you have an already marginalized population like this that is perceived to create a public health threat. The one solution would be to tackle that head on and do, as this slide points out, as Chesa Bodine, who's a progressive prosecutor in San Francisco, is doing, and that's quote unquote emptying the jails. That's one approach, and understanding that people need to get out of these spaces and get home so that they can socially distance and shelter in place and get this thing to stop. Or we decide that those places are the last places we're going to let anybody out of. And there's going to be staggering death tolls, and we will as a society decide that that's just the cost of doing business, because we will never let them out. And so one of the problems with the quarantine model, of course, is that there is a way that that can be done to just completely shut out populations from other populations, and prisons are going to be, or potentially, one of those spaces. So rather than let more people out, rather than let the elderly out, come home on a compassionate release, the fear always looms that we just seal that wall up. And I'm really concerned about that. But by the way, that is exactly the same concern I have for poor communities on the outside. I think we are moving alarmingly towards this idea that a certain number of death and devastation is acceptable in certain places. And no longer blinking an eye, for example, that in the city of Detroit, we are still, 1,000 cases a day. I mean, and yet there's a sense in which, well, as long as it's not here, wherever the here is somewhere else, then just don't go to Detroit, or
don't go to Detroit. Yes,
don't go to Detroit, or close down that prison even longer. Don't let people out. So this is a slippery slope, and I wish I could say some optimism about which direction. I hope there's such a powerful grassroots movement afoot right now to push back against this, inhumanely punitive system anyway. I would love for us to be able to take this and run with it, as I said, in a kind of a public health new weapon, a new public health weapon in the criminal justice fight. But if we don't politicize this, if I might say, make no mistake about it, it will be politicized, but it will be politicized in a direction that is deeply alarming to us.
Well, I share your I share your opinion on that one. We have a few minutes to talk. Address one more question, which I've been asking everybody in the conversation. I'm not specifically wanting to say, what do you think the lessons learned are, but you can respond to that if you like. But I guess the way I'd like to put it, if there's some obvious lessons drawn from the impact of the outbreaks of both from what you saw with TB that actually struck you so much with what happened with tuberculosis, and I would also add what has happened with HIV and control in prisons as well. What makes you hopeful that though many lessons were not learned from the past, what makes you hopeful at this point?
Well, I think that there's always hope that if we can just keep framing, pushing people to understand what this system is actually doing, not what it purports to do. I am heartened by the fact that every community that is able to express that opinion and is able to really share their stories from the inside and is really able to force people to look at what this apparatus in fact does and looks like, that there's a really kind of remarkable, outrage and horror that people feel when they actually know what's going on. So I guess what makes me hopeful is the power of education in that sense. And it sounds so cliched and so limited, But I don't mean activism just as in the classroom. I mean, like, social movement building education activism, that it's, people have to think about this to change it.
Mm-hmm.
And I'm optimistic that we are being forced to think about it increasingly and more, and that the folks on the inside who've experienced this most acutely are speaking out so loudly and refusing to be silenced, and that gives me a lot of hope. And I guess the biggest hope ties to the first part of your question, which is that the lessons from this are actually obvious if we just keep shining the light on them, which is, if you imagine your criminal justice system to be over there and away and separate, and you don't care because it's someone else's children that are in it, not yours, then that is a fool's game, because this system is not separate. And even if you don't care a thing about who's inside of it, the one thing that this epidemic shows, just as TB did, is that you might not know a single person that ever went to prison, but believe me, you are impacted physically, economically, socially. You are impacted by this, and that gives me some degree of hope, because I think people can be very self-interested, and maybe we have to move that, we have to push that a little.
I think that's a good note. I'm going to stop sharing the screen now and join you on screen.
All right.
And look at some of the questions that have come in. And I'm going to read out some of the questions, Heather, and I'll see if you want to answer one or if I want to take one. The first one came in early because as soon as someone saw that you were going to be here, they sent in a question.
Oh.
And so the question is, organizations like Release Our Aging People in Prison, RAPP in New York, and others have been trying to pressure the governor to allow for more releases in the face of the pandemic. They have had vigils outside the prisons, especially when there have been deaths, yet Governor Cuomo remains recalcitrant. And so the question is, what else do you think can be done to make people understand how dire the situation is and why it matters?
First of all, shout out to RAP, because that's absolutely right. I mean, the level of activism, vigilance, showing up, demanding that politicians are looking at this and taking it seriously is really heartwarming. And that gives me hope. Back to your previous question, is how much people have stepped up. In every state, there's lawsuits, there's activism, there's showing up, there's the vigils. And, and yet the governors and the DAs still say, well, for public health reasons, for public safety reasons, we can't do that. So I guess the only thing is to just keep hammering away at the irony.
Yes.
This is not public safety, and that if we care about public safety, we are going about it in exactly the wrong way.
Mm-hmm.
And part of that is going to be forcing the press and the journalists and the aides to those politicians to really force them to interrogate that proposition that this is about public safety. It is not. It is making us much less safe. And all of that is aside from all of the fundamental human rights reasons why they should do it.
Mm-hmm.
I think we need to attack the premise of why they're not doing it, which is that it makes us safer.
Mm-hmm. So I think that's right. I mean, clearly that there's going to have to be some push, some push, as many advocates have for, and I'm not saying it didn't exist in the past. Certainly there have been pushes toward the need for quote unquote prison reform, or the people who are arguing against mass incarceration, shutting down prisons, those kinds of things in the past and in the contemporary moment. But I guess what one of the questions suggests, are prisons being used as they have been in the past with issues to address issues, to look at issues of medical experimentation? I haven't read anything about that. So in the case of trying out new vaccines, for example, Is there?
Oh, this is all on the table. This is so it's so interesting because again, this is another reason why one has to be vigilant. No matter the decade, no matter the victory, you know, there's always this need for vigilance because, of course, the whole problem of medical testing in prison that was really, you know, horrific throughout history, but still, you know, in practice and alive and well into the 1970s, into the 1980s. You know, there's been real pushback against that. There have been protective laws. So, you know, there are measures to protect vulnerable populations from medical testing. But all of that said, there are enormous pressures to open up that confined population to testing vaccines, to testing all kinds of things. And let me just say, you know, they will be very persuasive arguments because if this is a population with a high concentration of, say, COVID, you know, there will be a lot of persuasive arguments. The problem is just like with prison labor, there's persuasive arguments, you know, job training and people want to work. It's all in how, what are the rules? Is this about choice? Is this about real choice? Is it about real consent? And we cannot trust the system right now to safeguard any of those things. And so it is alarming. I have not heard right now of anyone testing a COVID vaccine in prison, but I do know that there is every year, there is pushes on the floors of various state legislatures to allow the selling of organs, the selling of the kidney, to allow stuff to take place in prisons in the name of, again, the public good and public safety. Yes. So it's a fabulous question, and we all need to watch this really, really carefully.
So I absolutely agree. I mean, I depend on you to be vigilant and reporting as well. but I also think that in a more serious vein, people are raising questions about what level of investment should the state, I guess, be making in protecting prisoners' health. So for example, should we be asking, the question that came up in the chat is, should we be asking the state to financially support those who are given compassionate release? If many of them are older when they're released and can't possibly get a job to support themselves or take care of the health care, what's the role of the state in taking care of them?
Well, can I just say, I love this question because it goes back exactly where we were in the beginning of our conversation when we were talking about the gutting of welfare as we know it. The problem with a lot of our criminal justice reform discussions is that we are asking the question as to what should be given to prisoners, or what should be given, what should we do inside of a prison to, you know, make it better, more humane, or whatever. The question is a much broader question about how we treat marginalized, vulnerable populations. Mm-hmm. If we can solve that question, mm-hmm. whether or not someone has served time, whether or not someone has been inside, we can then focus on that. We can then focus on how many people are in prison and in closing prisons. But the bigger problem is that whether you're in prison or not, if you are poor, you don't have access to good health care. Mm-hmm. And if you have been sick and out of the workplace or unemployed simply because you can't get a job, you need to eat and you need housing and you need support from the government. So the question really, again, forces us to not ask about prisons as much as to ask about where we are as a society, that we would allow a situation where our most vulnerable, the majority of our population, can't see a doctor, has no housing, can be evicted in the moment. And incidentally, this is going to be on our public radar very, very shortly. Mm-hmm. All those waivers on evictions are going to expire. All of these people who are unemployed, who we are seeing marching on state capitals with the Confederate flag, is a symptom. I mean, everyone needs a job and is going to need to have food and shelter. So if anything, this is an opportunity to not ignore prisons, but to tie the condition of prisoners to what everybody else is going through right now.
Absolutely, to make it, to sort of speak in more universal terms.
Exactly.
For those people who are marginalized in various kinds of ways.
Because if we said, for example, that anybody who does not have an income of X is nevertheless going to have X protection, all prisoners will be protected. And here's one example of this. We used to have prison education paid by Pell Grants in prisons.
Wow.
And it allowed people on the inside to get a college education. And there was so much pushback against that. You know, oh, are you kidding me? Why are prisoners getting an education? Even though, again, from the public safety point of view, from the humanitarian point of view, from the human rights point of view, it makes total sense. But what people didn't understand is the reason why prisoners could get a college education was not because prisoners were getting some little favorite little Benny from the Pell program. It's because they were poor. And the same Pell Grant that would have allowed a prisoner to get a college education while they were inside was the same program that would let someone else's child get a college education.
Yes.
And so when we start focusing on the things for prisoners, we miss the fact that this is a human rights question that goes beyond prison walls too.
Yes, absolutely.
Yeah, I'm sorry.
No, that's fine.
I'm on a roll here.
That's what we want to hear. So I think that also, here's a question from a fourth year medical student in New York. Future plans are to be a family physician, and has started a COVID-19 evidence-based clinical practice working group at the Albany Medical College. And the topic, she notes, has become really important to medical students and physicians. And so she asked, what should physicians and medical students do right now? What should doctors be doing? And what would be the most helpful kinds of things? And so let me start because I've been intrigued by this program that started in Philadelphia. An African-American doctor started a program in Philly because it was so hard for so many people that she knew to get tested. They were being told that there weren't enough tests for anybody who didn't have any symptoms. They were told that even though they had someone in their household who was sick, or if they were told even though they had a crowded household and couldn't social distance, they still couldn't get any tests. And so she's in private practice. The first thing she did was put up a video to dispel rumors that African Americans didn't have some special susceptibility to COVID-19. That was the first thing she did. The second thing she did was buy a van and staff it with medical students in PPE and go and start knocking on doors in Black communities and offering tests. So to me, that was a very striking example. It brings to mind W.E.B. Du Bois and the Philadelphia Negro walking around Philadelphia house by house charting disease and those kinds of things in the far past. But that's clearly something that medical folks can do. When you're a historian, you always kind of we always go backwards to think about moments where we have these lessons that we can build on, and Du Bois, absolutely. But I'm thinking about even in the 1960s and 70s, how, the Young Lords Party and the Black Panther Party set up, health clinics because there was this acute recognition that health was everything and that you could not count on the system to provide that health. Well, it wasn't just these activist organizations. There were, after Attica, it was Black doctors from Lincoln Hospital in New York that drove up to insist on getting inside the prison to take care of the Attica brothers who'd been shot by the police. There's a long tradition and history of community health care and really pushing for that. And I think that's clearly one of the models. But I also think I want to bring back prisons in here for a moment to say that I'm really struck by, I periodically have had the opportunity to give talks about prisons to medical students. In fact, 2 years ago, I just did one at University of Michigan Medical School. And what strikes me is that that's not part of the curriculum.
And yet every physician who's trained in internal medicine, ER medicine, part of the checklist they do when someone is admitted is to ask whether or not they've ever spent time in a correctional facility. And the reason they ask that is because of all of those things: TB, hepatitis, HIV. And how can it be that even in our training of doctors, we have this bottom line recognition that there's some fundamental problem here with our correctional facilities?
Mm-hmm.
And yet one of the key electives that, or not electives, one of the key courses that our physicians should be taking is about this massive punitive criminal justice system that probably the majority of their patients who do not have private insurance are going to have experienced.
Yes. Yes.
So, you know, I would just say that this in Albany or Philly or wherever, educating doctors about what the risks in the criminal justice system are, and not just data, but
yes, not just data. Yes.
Yeah.
There is a long history of health advocacy led by physicians. Certainly, we know a lot about those in the past, and certainly in recent years as well. But the thing that I'm struck by is in those moments when, like a very, clearly committed medical student asks a question like that, it's also not in the medical curricula for them to understand how those efforts have occurred in the past, nor to understand how they can continue to be ignored in the present.
Exactly.
You don't have to reinvent the wheel.
Yeah.
The issues that I was talking to a friend earlier today about the fact that at Harvard Medical School, students had gotten together in the 60s and bought a bus and went through low-income neighborhoods in Boston and offered free, just sort of general medical care. Also, back in the 1940s, African-American women went through the South in a car with some basic things to take care of people who had absolutely no access to medical care. Those are part of the history of medicine as well in public health practice. But if you don't know those things, then you come into this moment and you say, oh, what could we possibly do? There's so much that one could do, but I would like to see at some point the leaders of both public health and organized medicine value those advocacy efforts and see how important they are and make them part and parcel of the education going forward. Because if they don't become part and parcel of how physicians are trained or public health experts are allowed to address in a systematic way, how are we not repeating what we've already seen?
Oh, totally. I mean, you just said that so beautifully. I mean, that's absolutely right. And it also, if that were much more part of people's consciousness and part of the educational system, it would also force, I think, larger organizations like the AMA to really be much more self-critical about positions taken on health, on insurance and on healthcare in general. I mean, once you see that there's this kind of long tradition of trying to do healthcare on the margins for the people who most need it, it's a little harder then to sort of say, well, single payer is crazy, or Medicare for all is crazy. Well, if you actually have some vantage point for why private insurance doesn't work from the people who actually administer it, then it gives it some weight. And so it's hugely beneficial.
Absolutely.
So the best doctors are those who have minored in AFAM and then gone to med school. Because of that, because of those stories, because of that sort of deeper history, for sure.
Yes. So we were close to out of time. I want to give you a moment to just wrap up and say what you'd like us to take away from the conversation from your perspective, or what we need to be thinking about as we unfortunately, and I'm really worried about, we're going to be seeing the numbers go up, and that's not going to be a good thing.
Yeah, well, I think the two things I think we need to look out for, just be kind of aware of and speak up if we see them in our own communities. One of them is this question of medical testing and what how that might come about and how it might be presented, and who needs to be at that discussion if that is again on the table. And then the other is really this question about, are we going to learn from this, push this idea that the borders between prison and the outside are porous, or are we going to run the risk of shutting down, becoming even more punitive? That, of all the things, I'm actually most concerned about. And so I'll give you just one quick, it's a little chilling, but it's something to think about. If you are in a supermax prison, right, you have very little human contact, and you are in one cell, and you often do not ever touch or see another human being. Even the guards are giving food through a slot, and there's no physical contact whatsoever.
This is the super isolation.
Yeah. And of course, there are many prisons around this country that are based on that. And some of the more notorious ones, like Pelican Bay or like, Red Onion State, and there's a couple. But every hospital has that ward. Every hospital has that, or that unit, if you will. And what we don't want is to take the world's largest pandemic that we've had in our history, our immediate history, and say, well, then the solution in our criminal justice system is more isolation. Because it is not a good thing to say the problem with prisons today is that prisoners aren't able to socially distance. Yes, that's true, but we have to do that really responsibly. Because socially distancing does not mean isolation. It does not mean that we're advocating for supermax prisons. It does not mean that we are arguing that people should never come home. And it doesn't mean that we are arguing that visitation should stop. That's another thing.
Yes.
We're not arguing that nobody should be able to see their families anymore. And so I think we have to be more vigilant than ever right now about taking an even more punitive turn after this COVID experience than we did even after tuberculosis. We won't, as long as we are really figuring out what's coming down the pike. And I'm fearful, but I'm also hopeful that we can avoid that.
Thank you. Thank you.
Thank you for inviting me.
You're very welcome. It was great to end on that note. So that's our time for today. And I really appreciate, Heather, that you were able to join us. And what you've told us is just, it's going to make for some sleepless nights, I hope, until we can figure out what to do. But knowing what we can't not know what you've told us.
Well, stay safe and be well. We will talk soon.
Okay.
Okay.
And for those participants, hope you can join us next week when I'll be talking with Paul Farmer about infections and inequality. So thank you all for coming, and take care.